I'm Shoshana Kahana. I'm a program officer at NIDA. I'm substituting actually for the moderator that's listed in your program. I'm going to go ahead and just quickly give an introduction to the speakers and their talks because as we know, you're here to hear them, not to hear me ramble on about my thoughts. So our first speaker is going to be Dr. Özcan. I hope I said that right. He is actually going to be looking and talking to us about detection of E. coli using a cell phone. The second speaker is going to be Kenzie Preston from NIDA IRP, and she's actually going to be talking to us about a smartphone study of Hep C and risk behaviors, HIV-Risk behaviors, and looking at those in the context of drug use cravings. And our final speaker will be Mia Vanderkop, who will be talking to us about some of the WellTel retain findings, which essentially is a text messaging intervention to improve patient retention in HIV care. Without further ado, Sean.
Good morning, everyone. It's a great pleasure to be here. So in this presentation, I'll go over some of our work on the use of cell phones for microscopy and sensing and diagnostic applications. I'd like to start with actually this slide, which gives you an overview of what's been happening for cell phones over the last decade in terms of their transformation. The components that we have at the cell phones. What you see on this, what you see on this slide is actually transistor count in CPU. So this blue line here, or the dots that are shown here, it is exactly the Moore's law. What tells you the density of computational elements in our computer chips, and as predicted by Intel's co-founder. It's increasing, or it's doubling every 18 months or every 2 years roughly. But what you see on the same plot is actually these red dots, which show the megapixel count of cell phones, our cell phones, starting from around 2002 till now. Very interestingly, it's also been doubling every 18 months or so, exactly following the Moore's law, which tells us that actually today's cell phones are really extremely competitive in terms of their hardware, in terms of their, at the same time, software capabilities. And they're probably better than the supercomputers of early 90s that IBM used to have. So this, when it's added with the fact that we have close to 6 billion cell phone subscribers, and actually, quite interestingly, 70% or more than that actually is being used in the developing parts of the world. And yesterday, I just learned another fact that in Nigeria, for instance, more than 40% of these cell phones are smartphones. And in Africa, it's more than 20%. Those are amazing numbers where we can utilize these cell phones as just more than talking and build unique devices that are especially going to be useful for telemedicine application. And that's exactly the theme of our research lab at UCLA. We're trying to provide a new platform using cell phones or technologies that are essentially coming from digital electronics to create new microscopes, new diagnostic tools, new microanalysis tools. What you see here are some of our prototypes. Literally, you can take a regular cell phone with a very cost-effective attachment, convert it into a microscope. This is the same thing for fluorescent microscopy purposes. To detect E. coli, we're using a very similar attachment. I'll talk about that toward the end of my presentation. And if you don't want to modify your cell phone, you're having here standalone microscopes that work based on the same principles, and it gives you a very lightweight, compact, and cost-effective interface to conduct microscopy. So this platform is referred to as Lucas in our lab, and I'll tell you more about Lucas today and how it's working. This platform technology does not really work like a conventional microscope in the sense that it is computational. It uses computation to simplify its architecture. And it's quite important and timely that computation can be used to simplify microscopy, because through cell phones, through the graphics processing units installed on our smartphones, computation is extremely cheap these days, and it's in our pockets. And that's why these microscopes are actually lens-free microscopes. They use computational algorithms to reconstruct images of cells from their shadows. And that also gives us a good advantage because these microscopes, because there are no optics in it, there are no objective lenses in these microscopes, they're compact and cost-effective, and they have a unique advantage, which is that they can look at larger areas. So telemedicine is one angle for computational imaging, the way we do, but there are other directions for computational microscopy that I won't highlight today, but especially for high-throughput imaging applications such as looking at, for instance, extremely rare cells in whole blood, you could also benefit significantly from these non-conventional computational microscopes. But I want to talk about these applications of computational imaging, but more focus on, again, telemedicine. So going back to the Lucas concept, it doesn't use any objective lens. It's essentially a computational microscope which replaces the physical lens with some algorithms. That's why we can only detect shadows of specimen. Unlike your own shadow, cells at the micron scale are quite small, obviously, but they can let light penetrate through and cast unique three-dimensional shadows. And that's what we start with. We capture these shadows, which are not dummy, not entirely dull in this case because the light has penetrated through, and they actually contain texture, which you can treat like the fingerprint of the cell. But more importantly, you can reconstruct the exact spatial information, the image of the cell, through these shadows. These are actually holographic shadows, and we reconstruct these to get back the images of the cells from these shadows to get back the regular images of these cells. These are red blood cells in whole blood, which nicely match the conventional microscope. That's how we essentially start with these oscillatory features, which are containing everything about a cell in a different domain, and then you recalculate it extremely fast. This image from this dashed square takes a millisecond, 1,000th of a second to compute, and it's extremely easy to do that. So that's essentially how this platform works. You get these meaningless or seemingly meaningless cell shadows. You reconstruct images based on these shadows. These are subcellular features of white blood cells, and platelets are shown here. The biggest advantage of this type of an approach, besides simplicity, the hardware being replaced now by entirely computation, is that we have a huge advantage for field of view. If you look at this image, for instance, the scale bar here is a millimeter. It's a lens-free reconstructed image. You're looking at around 2 orders of magnitude larger field of view compared to a conventional microscope that has the same resolution level. If you were to zoom into this image from one part of the diagonal to the other, you'd be seeing actually cells reconstructed with a very nice sub-micrometer, actually sub-0.5 micrometer resolution across, again, a very large area. And this is actually another more advanced version of the same idea. It's less than 100 grams, so it's lighter weight than your iPhone, essentially. You load the specimen from the side. There's no lens involved in it. It's a very inexpensive and still compact design. And you can actually see, in this case, malaria-infected red blood cells. These are conventional microscope images, and each one of these red pinkish dye is a Giemsa-stained malaria parasite, and the same thing with a lens-free microscope is reconstructed as shown here. Pretty nice resolution and contrast for these parasites, but the biggest advantage, once again, you can look at thousands of cells all at the same time within a very large field of view as shown here. It's important especially for looking at rare cells, and in this case actually malaria is also considered rare in the sense that it's typically less than 1% parastemia, and that's why you need to look at to avoid false negatives, you need to look at a large numbers of cells in a typical sample, and that's where the field of view can be quite advantageous. What is unique about computational microscopy is that it follows the Moore's law. In other words, as our computers, as our cell phones get better and better every 2 years, doubling their transistor density or doubling their pixel count, we're riding on a smooth curve, which is getting better in terms of our performance every year. And that's quite new for microscopy in the sense that microscopy, if you take an old microscope from 2000s or early 90s, give or take, I'm talking about commercially available microscopes, give or take a small fraction, their performance is the same. But computational microscopy rides on the Moore's curve, Moore's law, and that's why it's going to rapidly improve its performance without trading of anything. In just a couple of months, actually, as new sensors, as new imagers that are at the back of our cell phones come out from 5 megapixel to 10 megapixel to 15 soon, you can actually buy more field of view and improve the throughput of your imaging device without sacrificing resolution. And that's quite unique. This is actually a pap smear that's used to initial screening of cervical cancer. And you're looking at 30 millimeter square field of view here, which is improved from some 20 millimeters square of the earlier design without sacrificing resolution. Actually, in this case, also improving resolution. So it's a win-win situation, and the simplicity is an additional benefit. One application where these computational microscopes could be applied to is actually looking for monitoring of HIV-positive patients, looking for their CD4 lymphocyte count. CD4 is a lymphocyte, and unfortunately, HIV depletes it. We have, let's say, 1,000 to 1,200 for a healthy patient CD4 cells per microliter, but once HIV kicks in, that number drops to a few hundred, and that's when you need to start the therapy. So the gold standard for measuring the CD4 count every 3 months, ideally, is still a cytometer, like a flow cytometer, but these are relatively bulky devices. Even if you were to miniaturize these, which could be a suitcase size, the running cost would be quite high, on the order of $5 to $10. So what we've done is we've actually used spatial microfluidic devices made out of a polymer, almost plastic, very inexpensive, disposable, so that you can inject whole blood. And there is some surface chemistry within this microfluidic device to specifically capture these lymphocytes, CD4s or CD8s in this case. So you inject whole blood and wash it out. You can selectively capture these lymphocyte types and count them using these field-portable microscopes. So this is actually one example where we're looking at an HIV-positive patient sample. Each one of these spots that you see with faint circles is an antibody island. It's a specific cell type captured from whole blood. And if you zoom in, you would be seeing CD4s and CD8s in different parts of this chip. So you capture it and you count using these disposable microfluidic devices, image using lens-free on-chip computational imaging. These are some zoomed-in images of the same spots. These are the holographic shadows of CD4 cells. Another spot here, these are CD8s, from which you reconstruct and count the cell density. So this was actually a study for looking at the ratio of CD4 to CD8. So for healthy patients, actually the number was quite high, on the order of 3, the ratio of CD4 to CD8, but once HIV kicks in, that number drops to subunity, and that's where it could be used as a parameter to start the therapy. It gives you the proof of concept of the fact that lens-free computational imaging, together with some spatial microfluidic devices based on surface chemistry, could be quite powerful to bring in specificity and sensitivity that microscopy itself cannot have. So to summarize everything I've shown you so far was based on actually bright field imaging, based on shadows, but we have also created some other forms of microscopes which are actually fluorescent microscopes that convert a conventional cell phone into a fluorescent microscope with a very inexpensive and simple attachment as shown here, or a flow cytometer as shown in this image. This attachment is on the order of 30 grams or less. So you load the specimen from the site, and there are some light emitting diodes that excite it. The blue light here is the pump, the excitation source. And LED is the same thing that you have at the back of your Blackberries. Whenever there's a new email, that thing that blinks is a light emitting diode. So it's a very inexpensive technology. And you can this way look at very large areas in fluorescent mode. This is whole blood samples, and these are red blood cells imaged. white blood cells image in this case. These are some Giardia parasites in drinking water, and the bottom lines are conventional microscope comparisons for the same samples to show you that you indeed do not miss a cell. Can you click on this video just to see if it can work? Okay, so this is actually was supposed to be a movie which was working this morning. It's actually showing you that the same architecture, rather than capturing a snapshot image, it could also capture a movie of these cells. As you flush them through a microfluidic device, these are whole blood samples, and these are labeled white blood cells that you track and count, which can be used as a flow cytometer to give you the density of white blood cells in number per microliter. We've improved this technology since we introduced this platform, and currently we're less than 5% error compared to a culture counter. Commercially available culture counter. So you can do a flow cytometric analysis on the same platform. Another application is actually if you combine specific surface chemistry protocols on the same device, you can look for bacteria. And in this example, we've used the same underlying platform to look for E. coli using these microcapillaries. So what you see here is a bunch of microcapillaries with a core. These are glass-based microcapillaries with a core of around 100 micrometers. And the inner surface of that microcapillary is actually functionalized with some anti-E. coli antibodies. So if you flush several milliliters of water or milk sample that you want to test, essentially the E. coli fragments will be bouncing on the walls and will be specifically captured on the walls of the capillary. Then we have a secondary antibody which has a quantum dot attached to it. Then you flush that solution so that whatever is bound on the glass surface is now attached to a bunch of quantum dots, which are then excited using these LEDs. And then you see this reddish glow per capillary, and that reddish glow quantifies the E. coli density in that solution of interest. With this platform, we've achieved a good sensitivity of around 5 to 10 CFUs per milliliter for water and skim milk samples. It's hard to see because of the low contrast of the room, but essentially each one of these capillaries is glowing reddish to quantify their density. And it's quite also specific. We've done tests with other species, and it was also giving us a specific answer, in this case for E. coli. So what I've shown you today, to wrap up, is different technologies that can tap in this resource that we have around the cell phone in terms of the computational power, in terms of the optics hardware that's installed at the back of these cell phones being so powerful and so good. So it enables us to create new technologies that could bring in compact, cost-effective, and lightweight devices that are running at the back of these cell phones. Actually, several of these technologies have been licensed by a startup company called Holomic. It's based in Los Angeles, very close to UCLA. So if you want to learn more about the company, Holomic, you can visit their website. Their first product is actually a rapid diagnostic test reader that's running at the back of a cell phone. Essentially, this is a universal platform that can read immunochromatographic assays running on the back of a cell phone. There's an attachment which you can insert different RDTs, rapid diagnostic tests, and there's a smart application on the phone which, for different tests, you can capture the RDT interface on a spatial light emitting diode illumination, and then there is an application which gives you the diagnostic result, which you can then send to secure servers for spatial temporal analysis. So that platform is also now commercially available through Holomic, which has been licensed from our lab. So finally, within the next 2-3 minutes, I'd like to very briefly introduce our recent project, which has been launched actually as of yesterday, which is a platform to monitor feet, digitally monitor feet at the home using flatbed scanners. So you can learn more about this project by going to bigfoot.ee.ucla. Essentially, it's an application that you download for free from that website, which, if you have a scanner, flatbed scanner, attached to your PC, it communicates with that and gives the user the ability to scan high-resolution images of the bottom part of their feet, digitize them, register them, so that they can track as a function of time how these feed images are progressing. So you can actually daily or every week, you can scan your left foot and right foot using these buttons. And then if you have scanned images in your hard drive, you can compare how new images, each of which are aligned to each other, progress. And we also give you some more interface where you can actually look at this food image and define regions of interest, put some text to it saying, I'm not sure what this lesion or what this feature that I see, and actually track that across several days or weeks. If you don't like this, you can email this entire region of interest with the text messages to your doctor and get it back and forth. This is the home application, but of course we're also very much interested in point-of-care offices and clinics so that the doctors can also enjoy this very inexpensive platform in the sense that if you have a scanner, if you don't have one, buy it from Amazon or eBay for $10. But if you have one scanner, it converts your scanner into something that's very useful, especially for diabetic patients and post-op patients, where you can quantify everything in terms of how a scar has been enlarging or shrinking in size, because everything is quantified here. There's a ruler, and we measure everything based on aligned images. So I believe it's going to be a quite useful application. And now it's free to download. We just want to spread it and create a community of users, both from the patient side as well as from a professional side. So you can learn more about it. Finally, I'd like to conclude with with an acknowledgement of all of our students and postdoctoral scholars that are behind this work, as well as our funding agencies. Thank you very much.
We have time for one or two questions before we move on to the next speaker. No one has a question about that innovative? Okay.
My question is, if you have patients living somewhere in the United States, how easy would it be for them to just image, for example, what would they take, a sample of their blood, and then they would image it? Or how would this work so that you could then use these techniques in your office or use them in research? So you wouldn't have to have every subject having one of these, but rather they would take some sort of a blood sample. How would that work?
So we're not representing a company here. I'm representing my research lab and postdocs and all the students. So we're academics. So that part of the equation of how you translate these technologies to home for medical tests is an FDA-related question, which also significantly ties to the business model.
If you just want to use it in research, what would the client have to do? Would they have to?
I see. So if you just talk about research, then for instance, some of the devices that the cells were floating and you were counting, you just get regular blood, a few microliters from the tip of the finger, and then you can dilute it if you want to look for red blood cell counting. So typical sample preparation that you need to do with these, especially if blood analysis is concerned, red blood cells, white blood cells, or let's say hemoglobin density measurements, all of which we've done, you're talking about around 15 minutes of sample preparation, which takes the sample from the patient, dilutes, and depending on your application, you may lyse cells or not. If you're counting cells, you want to dilute depending on the density. For RBCs and white blood cells, it's a different dilution factor. For hemoglobin measurements, you don't care about anything. You just want to lyse everything and create a soup. So the sample preparation would change somewhere between 5 to 15 minutes, depending on which one you want to do. For instance, for RBCs, you don't need to label them because their shape is so unique. But for white blood cells, we label them with a fluorescent tag, so it takes the longest. It takes around 15 minutes with some incubation time to label. So it varies on what you want to do. But if you want to do research purpose things, it's going to take around 15 minutes for at least these three parameters that I said.
And this isn't something, it sounds like, that the participant themselves can do. I mean, they could collect...
Again, you're going from research to home use, which...
No, participants. So if you have participants out there and you're interested in their behavior and you're collecting these samples...
I see.
from the participant side of things, it sounds like you couldn't just have these people out there.
If they have some simple sample preparation background, as if they are technicians, I'm not saying they are nurses or anything, they need to go through some training, of course. I mean, after that, it's no, rocket science. Everybody can do it.
Okay, thanks.
In the interest of time, and just trying to protect the time of the others, we're going to move on to the other speaker, but I'm sure you're open to answering questions after?
Absolutely.
Okay. Great. Sorry, Ken. Okay.
Good morning. I'm going to talk about a different kind of use of technology, and that is some work that we're doing to use smartphones to study hepatitis C and HIV risk behaviors and triggers for drug use and craving. The reason that we're interested in HIV risk behaviors in our hepatitis C patients is that hepatitis C and HIV share many of the same risk factors, but in fact, hepatitis C is much more common and represents a significant health burden. So we feel that if we could learn more about transmission, we could develop better prevention methods. So what actually got us started in this is a study in which we enrolled methadone maintained patients and asked them to complete the HIV risk behavior scale every 2 weeks. And in this slide, this is time across time. And what we found is that early in treatment, HIV risk behaviors were very high, and they decreased over time. Shown in the top, this is the total score. And when we separated that out based on hepatitis C status, we found that it was actually the hep C positive patients who had significantly greater HIV risk behaviors. And when you look at the subscale, what this particular questionnaire is divided into a drug risk and a sex risk, it was really focused on the drug risks that were higher in the hepatitis C positive patients. So we are now doing a lot of work with electronic diaries, and we decided that we would further use those to further explore the risk behaviors. So the technique that we use is Ecological Momentary Assessment, or EMA. And in this technique, participants report their moods and behaviors as they go about their daily lives. And in our case, we're using electronic diaries. And the nice thing about EMA is that people make these self-reports in real time, and so it circumvents any problems of recall bias that can creep into self-report. So in this study, we used EMA in buprenorphine-maintained individuals to prospectively assess HIV risk behaviors in the field during actual drug use events. And we compared the real-time and the retrospectively reported HIV risk behaviors. And then finally, we compare the HIV risk behaviors and drug use triggers in our hep C positive versus hep C negative individuals. So the data that we collected were from a clinical trial that was run in our outpatient treatment research program in Baltimore, Maryland. We enrolled opioid-dependent treatment seekers, and these were actually enrolled in a randomized clinical trial testing whether clonidine would reduce relapse to heroin use. So this is the timeline of the study. It's kind of busy, but the important things to note are that the hepatitis C status was determined at baseline with serology, and that throughout this trial, participants received standard treatment for opioid dependence, which included weekly individual counseling as well as daily sublingual buprenorphine, and the participants came to our clinic every day to receive the buprenorphine treatment. In addition, they completed the HIV risk behavior scale repeatedly during the study, and we collected objective measures of drug use through urine drug screens and breath alcohol testing 3 times a week. So in this study, participants had a quick deadline when they had to stop using opioids, so test negative for opioids, and remain abstinent for 2 weeks. And if they met that criteria, they were randomized to clonidine or placebo, and they were given an electronic diary to collect EMA data. And that's primarily what I'm going to present today. So in the study, our participants carried those smartphones around with them for 20 weeks. And we asked them to make 2 different kinds of entries. One of those was an event contingent entry, so the participants actually initiated an entry whenever they used opioids, cocaine, or both drugs. And the other kind was a random prompt, so the electronic diary would prompt them during their waking hours 4 times a day to make an entry. And the questions that they answered included things like who are you with, what are you doing, where are you, in a general sense. We asked them to rate a number of mood items. We asked them to rate their craving for heroin and cocaine. We asked them about their exposure to drug use triggers, or in the use events, actually, why did you use? And we asked them to report on certain HIV risk behaviors. And the HIV risk behaviors were questions taken from other risk behavior scales. So each time they reported using, we asked them if they used a needle, new or used needle, the number of people who used that needle before them, and the number who used the needle after them, and whether they cleaned the needle before use or after use. So this is a demographics of the participants in the study. There were 67 of them at the time that we pulled these data. The hepatitis C rate was 22%, which is kind of interesting. 15 years ago, we had a rate of about 60%. 5 years ago, it was 40%. Now it's 20%. So it does look like hepatitis C rates are going down, at least in our population. There were no differences in gender, but there were differences in race, ethnicity, where Caucasian patients were overrepresented in the hepatitis C positive group, and African Americans were more common, overrepresented in the hepatitis C negative group, and there was no difference in age. This is the drug use history, and there was no difference in overall years of heroin use or cocaine use in the hepatitis C positive and negative patients. However, when you looked at route of administration, in fact, the hep C positive patients were more likely to report using heroin intravenously and also to use cocaine intravenously. When we looked at the EMA data and looked at the event contingent entries, if we looked relative to the proportion of random prompts, there was no difference in their rates of reporting of heroin or cocaine use, or both. And this was consistent with the results of the objective measures of drug use based on the urine drug screens. As far as HIV risk behaviors, if you look at these various items and you look at the hepatitis C positive patients, you can see they're all in sort of the direction of having greater HIV risk behaviors. However, the only one that was statistically significant was using a needle that someone had used just before. And in addition, there was a trend for them to report not cleaning the needle after they use, so potentially transmitting to someone else after them. This is a result of the retrospective HIV risk behavior scale. It's the same scale that was in that first slide, and as in the first study, we found higher total scores in the hep C positive patients compared to the negative patients, and it was specific to the IV drug use risks. Again, this was statistically significant, but no difference in the sex risk. We have done some preliminary work to look at the correlation between the HIV risks that were reported in the EMA data and in this retrospective HIV questionnaire and found a significant relationship. So one of the problems with EMA questionnaires, of course, is that they're not validated, but this gives us some confidence that, in fact, we're measuring actual behaviors. We also ask our participants to tell us why they use each time that they reported using. And we found that the hepatitis C positive patients were significantly more likely to report that they used because they felt frustrated, that others were being critical of them, that they felt worried or bored. And interestingly, when some of these measures were in the mood questionnaires, and indeed their ratings of negative mood was significantly higher in the hepatitis C positive patients. Interestingly, they were significantly less likely to report that they had used because they felt in a good mood and wanted to celebrate. And the hepatitis C positive patients were also more likely to report that they wanted to see what would happen if they used just a little bit, so sort of testing their willpower. They felt more tempted out of the blue. They were used more often because they handled cash or because they saw someone else use. So in conclusion, these real-time self-reports given on the smartphones showed that hep C positive patients compared to hep C negative patients had similar numbers of use episodes, and they also were using heroin and cocaine about the same rate. However, they were more likely to share needles, and they cited negative drug states as a trigger for use more frequently. So we think this study supports the need for tailored interventions for hep C positive patients with special attention paid to their negative mood states as triggers for use, as well as their needle sharing. And this may help us better prevent transmission of hepatitis C. We also think that it supports the utility of EMA for monitoring HIV-Risk behaviors. So I want to acknowledge our clinic and patients and staff, our intern Alex Jarowski, our biomedical informatics section that did the programming on the EMA, and support from the NIDA IRP. Thank you.
Thanks for that great presentation, really interesting study. I've heard of the same technology being used with sex workers in Indianapolis that was provided some really interesting information and very valuable. Can you tell us a little bit about your experience with actually giving the participants smartphones? How many of them had experience with phones before? Were they losing them, selling them? And also, what type of a phone was it? Was it a full-feature smartphone, or was it just a little bit about that?
Yeah, so I will admit that we have an advantage in that we have methadone maintained or buprenorphine maintained patients, and they come to us every day for treatment. But we've been surprisingly happy with their ability to use this. And it varies a lot by individuals. Some people just cannot get it, but many people do it. Our rates of compliance are in the order of 80% of the random prompts or better now. We're actually up to 90% because we're much more closely monitoring them, and we actually reinforce good compliance. In the first study, we lost one one PDA at that time for every 226 patient days. So not bad. I mean, I've had postdocs that broke more electronic devices than them. And let's see. We just recently switched from using a Palm Pilot PDA to these Windows-based smartphone. We don't have we don't have SIM cards in them to use them as wireless devices, but otherwise I think they would qualify as a full-function smartphone.
I'm curious about the EMA itself. Was it an app, or was it a web-based survey that you provided a link to them, or was it like native to the phone? So
our bioinformatics section took an original program that was freeware for the tungsten or for the Palm Pilot, and modified it to have some of the features that we wanted. But the programming is on the phone itself, and then we have a program to download it into our electronic medical records
So
system.
they had to come in and give the phone to you to actually download all the information rather than just transmitting it?
Right. When we balance the costs and the benefits of wireless versus just having it on a PDA, for us, it was more cost effective, and we saw them every day anyway. And there are other issues with, when you're using cell phones, if people are in buildings where there's no connectivity, then you have problems with that. So it's what worked for us.
Thank you.
I think it's a great talk. I think it's a good example of integrating mHealth into studies that are justifiable for other purposes. And Rich, we actually, in the out-of-treatment population, similar to Kinsey's, but they're not in methadone, we actually see very similar rates of adherence and compliance. I had a question about, I'm surprised actually that the Caucasian high-risk network wasn't different. We see older African-American heroin injectors without the negative mood who have Hep C from long ago. So it's interesting that even in the same city, we're tapping into different networks. I wondered if you assessed HIV status, and was that included as an exclusion criteria, or was that assessed?
We do assess HIV. Well, it's voluntary because it's not an exclusion criteria for our study, but we have very low rates of HIV positive. It's certainly less than 5%. So they're probably all in your study.
Okay. And have you entertained any ideas? I don't think we've talked about this, but any thoughts about assessing social networks using these devices in your study population, or at least getting a retrospective social network assessment?
I think that's a terrific idea, and we have not done that. So maybe we can try. I think our IRB may have some questions about that, but it's a good idea.
Uh-oh. It's not the first one. Okay, here we go. Okay, good morning. Today I'm going to provide you with an overview of the WellTel-Retain trial. It's currently in a pre-enrollment phase, so unfortunately I don't have any results. The primary aim of the trial is to evaluate whether the WellTel text messaging intervention can improve retention of HIV patients before they start treatment. First, I'll talk about the study setting, how the mHealth intervention was developed, and then I will outline the various studies that will be conducted as part of this research. The setting of the project is in an area of Nairobi known as Kibera, an informal urban settlement of about 2 square kilometers. Because we're in the States, I should probably say that's 0.7722 square miles. Kibera is the second largest slum in Africa, and its population lacks or has minimal access to basic services such as running water, sanitation, and electricity. The official estimate from the 2009 Kenyan census places the population at 170,000. Mapping projects that have been done place the population a bit higher, between 200,000 and 300,000. Between 10 and 15% of Kibera's population is infected with HIV, compared to a national prevalence of 6%. Pictured here on your right is Dr. Richard Lester, my supervisor in Canada. While he was living in Kenya, completing his HIV immunology fellowship, together with his colleagues, he noticed the rapid spread in mobile phone use and started to think about ways that cell phone technology could be used to improve HIV care. Together with healthcare providers and patients, Dr. Lester and his colleagues developed an mHealth intervention involving weekly check-ins. Each week, the message Mambo, meaning how are you in Swahili, is sent to patients. Patients are instructed to respond within 48 hours, either that they are okay, sawa, or that they have a problem, shida. If patients respond that they are well, they are simply sent a message again the following week. If patients respond indicating a problem, or if they do not respond, then a clinician calls them to provide triage, advice, or general support. To test the effectiveness of the intervention, Dr. Lester and colleagues conducted a multi-site randomized controlled trial. They recruited 538 patients initiating antiretroviral therapy from 3 sites in Kenya. Participants were randomized to a control arm, which is standard of care, or the intervention arm, which was standard of care plus the weekly text messages. The primary trial endpoints were self-reported treatment adherence and suppression of viral load. At the end of 1 year, patients who had received the messages had greater adherence compared to those in the control arm, and perhaps more importantly, due to the limitations inherent in self-reported adherence, they had improved suppression of viral load. Significantly, patients receiving the service felt that somebody cares. A subsequent trial conducted by Pop Ellish and colleagues confirmed the effectiveness of weekly text messages as an adherence support tool, and a recent Cochrane review cited the original WellTel trial as the highest level of quality evidence. After I joined Dr. Lester's team, the National Institutes of Health put out a request for applications entitled Promoting Engagement in Care and Timely Antiretroviral Initiation Following HIV Diagnosis. We partnered with the African Medical and Research Foundation, who had identified retention in care as a major issue, and submitted a proposal to determine whether the WellTel intervention could help engage patients in pre-ART care. This successfully funded proposal forms the basis of my thesis research, which I am undertaking at the Karolinska Institute. Karolinska has a long history of collaboration with MRAF and has been involved in research in Kibera for over 10 years, making them a welcome addition to our research team. So why is the NIH research community and program providers concerned with engagement in pre-ART care? First, it's a huge problem. Rosen and Fox, 2 eminent researchers who have done comprehensive work in retention and HIV care in limited resource settings, did a systematic review which found that less than 1/3 of patients testing positive for HIV remain continuously in care until they start HIV treatment. The problem with not being retained in care from the time of diagnosis is that patients then return to care when they are seriously ill and initiate HIV treatment late, which results in a significantly increased risk of mortality and a greater use of healthcare resources. To determine whether regular contact with healthcare providers can help engage patients in care, we will conduct a randomized controlled trial at the Kibera Community Health Center, a comprehensive care clinic in the heart of Kibera, which serves over 4,000 HIV-infected individuals. We aim to recruit 686 participants, or 343 in each arm. Patients will be eligible to participate if they are 18 years of age or older, have a cell phone or regular access to a cell phone, HIV positive, and have an HIV test at the clinic. Recruitment is scheduled to begin in January. Patients will be followed for 1 year with a primary trial outcome of retention in care at 12 months. Since patients have increasing options as to where they seek their care, we want to ensure that our primary outcome measures retention in care rather than retention in clinic. Therefore, after the trial portion of the study is complete, we will actively trace patients who have been deemed lost to follow-up in order to ascertain their true status. In other words, whether they have transferred care, died, or are truly lost to care. Ethical approval for the study has been received from the AMRAF Ethics and Scientific Review Committee and the University of British Columbia. The trial has also been registered with clinicaltrials.gov. Aim 2 involves determining whether the SMS intervention improves retention in Stage 1 pre-ART HIV care. Rosen and Fox have defined Stage 1 as the time from a positive HIV test to the receipt of CD4 results, which is when ART eligibility is determined. Participants will be enrolled at the visit at which they are tested for HIV. However, clinic staff will assess patient readiness for enrollment. If they cannot be enrolled at the first visit, they will be enrolled at the subsequent visit. Loss to care between these first 2 visits will be recorded. Secondary outcomes include ART initiation for those eligible at baseline and the level of patient engagement in care. And this is primarily with 12-month retention in care as a primary outcome. It's almost unfair if someone just comes at 12 months, but they haven't come to all their other appointments as well. Given the low cost of the SMS intervention, its use of existing technological infrastructure, and evidence that other electronic adherence interventions are cost-effective, it is suspected that the WellTel program is cost-effective. However, a formal cost-effectiveness evaluation has not yet been done. This study provides an ideal opportunity to prospectively evaluate actual expenses relating to the intervention, enabling us to perform robust cost and economic analyses. Our economic evaluation will examine the incremental costs and benefits generated by using the SMS intervention versus standard of care. The outcome of our cost-effectiveness analysis is the incremental cost-effectiveness ratio, based on the within-trial effectiveness of the intervention. Given the lifelong nature of HIV, we will also use established models in the disease to examine the cost-effectiveness of WellTel expressed as the incremental cost per life year gained. The trial offers the opportunity to conduct an important sub-study, quantifying loss to care in the pre-ART phase and determining factors associated with attrition. In their systematic review, Rosen and Fox noted that there is a lack of studies that adequately quantify patient loss to care from the point of diagnosis, even within one clinical setting. The trial will enable us to prospectively follow patients through the first stage of care up until 12 months. Patients who are ineligible for the trial, perhaps they don't have a cell phone or access to a cell phone, can still participate in this sub-study. A baseline questionnaire will be offered to participants so we can ultimately determine risk factors associated with loss to care. Acknowledgements. I'd like to thank MRAF, who's been super enthusiastic and an excellent partner in this research. My supervisors in Sweden, Drs. Ekstrom and Awiti, and then David Ojaka from AMRAF. Richard Lester, of course, for his invaluable support. With a WellTel retained, I know this is long, like an award ceremony or something, WellTel retained co-investigators, and as well as NIH for their financial support. That's it.
Wondering if you plan on paying for the SMS services for these participants. And it seems to me that they might have a lapse in SMS over the time of being enrolled in the program, and if you're going to, how are you plan to deal with that if they have a lapse in cell phone service?
Well, yeah, in the original trial, it wasn't a huge problem. There were instances where people weren't responding, but we found that even non-responders would end up re-engaging with the system. So if someone doesn't respond, we try and call them. So we did find that in the first trial that people did re-engage despite not having credit sometimes or not having their battery charged or these kinds of lapses.
Since a lot of the initial HIV positive people in Africa tend to be very young, particularly young girls between 16 and 18, I was wondering why you set your lower age range at 18 and not at 16 or some lower age.
You know what? I do truly believe that this intervention would be super effective in a younger age group. Unfortunately, to enroll participants in Kenya, you have to be the age of majority, which is 18. So although I think it's a great idea, and we've actually proposed doing so in a grant that we're currently applying for, it was not possible, but I do appreciate that point.
Good luck with your dissertation.
Thank you.
Where are the new HIV diagnoses being identified? Is this outreach testing, or is this just routine testing in existing clinical infrastructure? Because I think if you think about the continuum of care, outreach efforts to get people diagnosed earlier, those people may not actually be different than the people just presenting for care at a routine clinic.
Yes, and
Are you tracking that, and where do most people do you anticipate that will come from?
So it is a comprehensive care clinic, so there is some provider-initiated testing at the clinic where patients are asked. Yeah, or patients are referred, but you're right, it's not going to be necessarily generalizable to all settings.
Are you going to change up the messages, or is that always going to be mambo every week? Because we heard yesterday that at least in the U.S., patients don't respond to the standard, repetitive messages.
You know what? We did find, we did use Mambo over the course of the last trial, and it was a 12-month study, and we didn't experience a change in non-response, whereas I think, and maybe it's because also of the frequency, maybe it's because it's once weekly versus if you're inundated with the same message several times a day or maybe even every day, it might make a difference. Yeah, it's definitely an idea that we can entertain. Right now we don't have plans to do that, but yeah, it's a good thought.
Okay, I'm Dr. Amada from South Africa. Our scenario is a little bit different where most of our patient comes with CD for less than 350, therefore they don't really stay on care. There's no pre-ART, very few actually retain on ART. And those who are retained on ART don't stay long before they come back for ART. Really 1 year may be too much for them. And we have the population who are healthy when they test and are very mobile. It's really, they keep moving from one province to the next. And I'm actually worried that in 1 year, did you not lose a lot of patients who tested positive initially?
Yes.
In 1 year, they are either all on treatment or migrated or have very few remaining. And did it affect your outcome in analysis?
Yeah, and I mean, I think that's, I mean, obviously using an mHealth service is not going to change anything structurally with why people don't come back to care, but it is the problem that we're trying to tackle, right? And those reasons that you had mentioned are part of why people aren't retained in care. And I think a big part of it too is that if you're feeling healthy, then you don't see the need to be retained in care. But I guess that's what we're aiming to see, is that if we can keep up this continual engagement, that perhaps we can help those patients or encourage patients to come back to the clinic. But yeah, that will be seen over the course of the next year or two.
Thank you for the presentation, Liana Sarkisian with World Vision International. I'm just curious to know whether or not you looked at other factors contributing to the retention or coming back to treatment for their follow-up visit, especially community health worker programs. Was the SMS the only thing that helped these patients to come back and continue their treatment, or you looked at other factors that may have contributed to the patient's adherence to treatment, such as the volunteers, community health workers that might have also worked in that area in Kibera?
Yeah, so I think, and that is actually part of AMRAF's care in Kibera, is to have community health workers. So I guess the only difference between the two groups, once we initiate the trial, will be whether or not they receive the intervention. So while we'll examine factors associated with attrition, et cetera, but that is the one difference between the groups that we will be looking at.
So you haven't looked in the earlier one that you said the ones who received SMS was higher there?
Yeah, so in the previous trial, the only thing that we had looked at really was treatment adherence and suppression of viral load. So retention and care, it wasn't an outcome of the trial, really. I mean, we looked at loss of follow-up, but not in the way that we will be in this trial.
But even in that trial, I'm just curious to know, because, just how do you know that just receiving an SMS was the only contributing factor for them, as opposed to other factors in the community?
Well, and I think that is the beauty of an RCT. So I really think, when you have a group and you randomize them to either the intervention or the control, those two groups should be the same in all ways except for whether or not they receive the intervention. So, yeah. And I think that's why important to.
But you didn't have a question whether or not, did you receive any other, interventions, any other messages from the community?
Yeah, well, even
as a patient.
Yeah, I'm sure in follow-up questionnaires, and there's also qualitative aspects to the study that will flesh those things out.
I was just curious.
Yeah. No. Anything else? Am I released?
Yeah.
Okay.
Oh, no, wait.
Oh, no.
No, there's a lot of interest.
I work with HIV-Risk Ghana, and I'm the officer in charge of our mobile health intervention. And we send daily adherence messages on our to PL-HIV who are on treatment. And we all know that in Africa, there are some people who cannot read and write. I know this is a controlled trial.
Yeah.
But people are supposed to respond to your text messages.
Yeah.
How are they able to do that if they cannot read or write?
Okay, well, one thing...
Did you address that?
Well, it is obviously a very important consideration. So I'm glad that you asked that question. So one thing is that we've kept the messaging really simple. So Mambo, Sawa, Shida, it's quite simple and I think can be taught. And the other thing is that in the previous trial, what some people did was they had, for instance, their grandmother in the trial who had her grandson text messaging on her behalf. So people were quite innovative in finding ways to respond.
If I just throw light on what we do to address the challenge, is that we send the messages at a specific time of the day.
Yeah.
Maybe in the morning by 8 the message is gone. And every day people know that the message comes at that time. So whether you can read or write,
Yeah.
you work with a target group that they know that messages are sent. So far the message comes on your phone, you know that the message is done. And then we have a simile. So at least if you cannot even read, you can see. You can see the picture that comes with it.
Yeah,
and that
that's a
makes
good
you
idea.
know that it's time to take your drug.
Yeah. Yeah, I'd like to talk to you after about that. That would be great.
Okay, final question.
This is actually a comment. It's kind of in response to your question. I think it's important for us, especially for a target audience, to say, well, what are the normative kinds of repetitive communications that people receive? And so they wouldn't be problematic. So when we call someone, we say, how are you doing? And we say that all the time. And so it's important to differentiate messages that are fairly structured and very specific with communications that are repetitive and normative for the target audience.
Yeah. And I think one way of doing that, too, is by, as you suggested, so what we did was we sent the messages out previously every Monday at 9 a.m., so then you have an idea. And same with even in BC, we have a pilot study at an HIV clinic there, and the how are you, it was too generic, so it ended up being are you okay, which it changed somewhat, but it made it more, they understood who it was coming from, or it seemed like a better message to be sending. Yeah, am I free?
Thanks, everyone.